I know everyone's so busy. It is a tough time of the year, but welcome to everybody. Happy New Year. We are so honored to have you all on our call, all of you CMDA members and our guest speakers and presenters. Thank you so much for joining us. I'm Dr. Sing Palat, the president of CMDA. And we're very excited to have some wonderful guests today to speak to us. And our very first one will be Jenny Albertson with CHCA, and she has some announcements to start us off with. Go ahead, Jenny.
Well, good afternoon, everybody. It's officially afternoon now. Just a quick little update on what CHCA is providing for us all in the near future. Our educational offerings right now include some training for food, nutrition, and dining services. That's like a 3-day global training for your personnel and dietary, particularly geared toward dietary managers. There is a suspension currently in place for the requirements for an RD in the role of dietary manager. So right now is a good time to beef up the training for the people that you do have and help get ready for that. There will also be some offerings coming up for safe patient handling practices from OSHA, as well as workplace violence prevention programs from OSHA. We may end up rescheduling those depending on the level of interest. It looks like this is maybe not the best time for the people that wanted to participate. So that might be rescheduled. So stay tuned if you need to send people to that. You might have an opportunity in the coming months. In February, we are hosting a certified medication assistant training that will be across the whole state virtually, and will allow the whole classroom portion to be taken care of for that certification. So we are assisting facilities that are participating in finding clinical locations for the competency portion of that training so that they can add that to their arsenal of dealing with staffing shortages, particularly when it comes to managing nurse carts. So obviously a CMA cannot chart and assess an individual, and they do have to function under the guidance of an RN assessing the appropriateness of a medication administration, but they can actually do the pill passing. So that does cut down a great deal on the nurse's time, and it allows you to kind of spread your nurse a little bit more thinly based on our need for that right now. So that's why we're trying to offer that. It'll be very inexpensive for the facilities. It looks like a $200 per facility cost, no matter how many people they have in the training. And if you consider that it's a 9-day long training, that's pretty incredible. So I'm really excited about that. That's being provided by Joyce Humiston and her group down in Southern Colorado. They do it all the time, so it just fit for them to do that for us. Also, there's some hot button issues out there right now around staffing. There are people asking whether the state is entertaining waiving the 24-hour-a-day, 7-day-a-week RN requirement, and currently there is zero traction on that. That's a statute, and they are not even talking about removing that at this point. If there is an opening, we can certainly go that direction, and we're kind of keeping our eyes and ears peeled for when that might be considered appropriate. We're also contributing a voice right now to a potential additional training requirement that is proposed as potential legislation right now for dementia training. It sounds like a good idea on paper, and then you read it and find out that it is essentially asking members to have 6 hours of required dementia training for every person before they ever have the potential of encountering someone with dementia, which poses a lot of problems, as you all know, based on inappropriately diagnosed folks, very specific training needed for particular types of mental impairment. It's just not a very good bill, so we're contributing our members' voices on that. So that is the latest and greatest from CHCA. I'm sure the state will have their own tidbits. I will contribute state regulatory updates on the biweekly call on the 5th as well, and summarize some of what we've received in the long-term care update calls.
Thank you so much, Jenny. Really appreciate all the work with CHCA, and the training is so needed right now. So I'm glad that your organization is taking the lead on it. Well, now we will turn to our speakers from the CDPHE. We're so honored to have several people today. We have Scott Bookman, the Director Division of Disease Control and Public Health Response and the state's Incident Commander for COVID-19, as well as Elaine McManis, the Director of Health Facilities and the EMS Division. and they will be followed by Bridgett Clawson Braaten, Deputy Director of Therapeutics. Welcome to our meeting. Thank you.
Scott, do you want to kick us off?
Yeah, I just wanted to jump on here really quickly and take a moment to thank all of you who had facilities in the area of the Marshall Fire last week. This was a remarkably devastating event, and we all had to move incredibly quickly to move a lot of people to safety in a way that I think we may have never had to do at a scale like this before. And so while I do spend most of my life talking about COVID, I do oversee all of the other public health response, emergency response for the state, and really did just want to take a moment to get on here and thank each of you for your participation in keeping everybody safe this week. We will be putting COVID resources into facilities that either had to move people or accepted other people, just with concerns about outbreaks associated with that mixing. And Bridgett is here to talk about the therapeutics and how we'll scale those if we can in some of your facilities, but really did just want to come on and express our gratitude. So thank you.
And I'll just add that when our team joined the incident command to work with the facilities, contacting them that were both in the evac area and the pre-evac area, we observed swift, coordinated efforts to get those facilities evacuated. There was great coordination between the facilities, both on the side of the hosting facilities and on the evac facilities. There was wonderful internet or networking between the facilities on outreach, who to contact for staffing and supplies. Many times when we contacted folks in a facility, the word had spread to other facilities. So I just wanted to thank each and every one of you and your facilities and your industry for doing such a great job with this evac. We lost nobody as part of this fire in a residential facility. Thank you.
Thank you so much. For sure, there are people right in our communities, either personally or with their friends and families, and certainly with their patients who were impacted by the fires. Appreciate all your support.
I will let you know quickly that we will continue to do outreach to facilities until all of the residents that are displaced to host facilities have a final disposition. And we keep checking on staffing and any needed supplies as well. And we're doing coordinated calls with EPI in regards to COVID as we move forward. So certainly if any of you have any needs or you hear of anything, please don't hesitate to reach out.
We appreciate that. Thank you, Elaine, and thank you, Scott. Bridgett, did you have some prepared remarks, or do you want us to ask you some questions? Because I know that there's a lot going on right now with COVID therapeutics. It looks like you're on mute.
Whatever works best for you. I see that you're going to speak to the HAN, and that speaks a lot to the monoclonal antibodies and the antivirals that are out there. And so I don't know, whatever works easiest for you. I don't want to speak to the medical piece if you're going to.
Sure. Well, I know that a lot of our members were looking forward to the clinical piece, but in terms of getting supply, a lot of people are asking, if I have a patient with COVID right now, I want to put them on sotrovimab, Paxlovid, Malnupeurovir. Can I get that medication?
Right. That's we're hearing that often. So due to the mutations in COVID and the Omicron variant, only one, as you listed, the sotrovimab is seen as being effective against Omicron, and we are receiving very little amount from the federal government. With that being said, they've promised that they're going to start ramping things up and that we will be getting more into the state. So if you are interested in receiving any, I think it's important that we make sure to gauge that, that you would like how much you would like, what your throughput would be, and that information so I can pass it on to the program manager. With that being said, we've already sent out one round of antivirals. to the state, and we're just getting a very, very limited amount of Paxlovid and Stromovad in particular. So I ask of you, if you are interested in receiving some of that, if you can send me like your point of contact, what you're interested in, and like what you believe your throughput could be, so that we can take that into consideration in our future modeling. The first few weeks, we've really just focused on pushing things to high throughput providers. And now we want to expand upon that model and include, you know, more people. So that's a long way of answering your question. My apologies.
I'm glad you're working on it. So is it okay to share your email then with our members?
Absolutely, please do. So again, location, point of contact, what you think your throughput will be. I can't make any promises, obviously, but I want to put that into, you know, our minds so that we think about it when we're modeling and making sure we get that geographical equity. And we're looking at federally qualified health partners and high throughput providers. And, you know, I hope the federal government delivers with their promise of amping up the Sotrovimab in particular, because 2 weeks ago, we only received a little over 700 for 2 weeks for the entire state of Colorado. So it's pretty difficult.
Yeah, you'll go through that very, very quickly. Another question that has come up is that we all know that the CDC changed some guidance for return to work for healthcare providers with either exposure or infection with COVID-19. Are our nursing facilities allowed to go ahead and follow the new CDC regulations for those isolation and quarantine? I don't know if Chad or Elaine or Joe might want to speak to that.
Sure, I'll be glad to. I do know we've had those discussions with our EPI group, and because the RCF links directly to the CDC that has those that guidance in it, that's what at this time what they are, that residential care facilities are supposed to be following, whatever it says in that link. So that may change in the future. I think, as we know, guidance changes frequently, but at this point in time, yeah, follow that guidance that's in the CDC link.
Thanks for clarifying. Are there other questions that people have for our members of the CDPHE?
I was going to ask Joe, and I've only been here a few weeks. Isn't there an open office hours that everybody could attend as well?
There is an office hours that is that EPI does have, and then they have a residential care meeting every other Wednesday. So there isn't one this week, but next week there is. Is there one this week? I haven't looked at my calendar. I'm sorry. Is there one this week? You can tell by Dr. Palat's face, it looked like there was.
I believe there's one tomorrow.
Okay, then yeah.
So we'd love to get more updates then too.
Yeah.
Thank you. Thank you for all your information and for supporting us in our work in the nursing facilities. Oh, are there questions in the chat box?
I see there was a question about Evusheld. Yeah.
There is.
Do you want me to answer that one?
Yes, please, go ahead. The question is, will nursing homes have access?
Yep. Okay, so the first round of Evusheld went out to our transplant centers in a few other locations. So that's another thing, if you're interested in it, please let us know. We really wanted to target the most vulnerable in that first round and then start to spread it out. So we are getting another allotment this week. And if you're interested, please let us know. I sent you my information as well as David and Sarah's, and David oversees monoclonal antibodies and Sarah oversees the antiviral piece. So please let us know if you're interested in that as well.
Perfect.
Hi, this is Malcolm Fraser. Can I ask you a quick question about the 5-day return to work, please?
Yes, go ahead, Malcolm. Thank you.
Thank you so much. Well, one of my facilities this morning got an email from Tri-County Health Department saying that the health department wants to discuss the 10-day return to work requirement. Do the individual county health departments have the authority to overrule the CDPHE? In other words, CDPHE says 5 days. Can an individual health department say 10 days?
I do know our EPI group is meeting with the local health departments today to discuss this and some of those discrepancies. So that's all I know right now. So it sounds okay. So I don't mean to be provocative or antagonistic, but it sounds like potentially the facilities need to do what the health department says, that the local county health department, and if they say 10 days, then we need to go with 10 days, even though the state guidance may be 5 days. Is that a fair summary? You know, it's really difficult because that's EPI that's dealing with the local health departments. So I guess I don't have a good answer for that, but I can try and get one for you, Dr. Fraser.
Thank you so much. That would be extremely helpful. And
Sure.
Thank you for the excellent work that you're doing in these very difficult times.
Thank you. Bye-bye.
Thanks for that question. If there are any other questions, go ahead and put them in the chat box. Otherwise, we can go ahead and turn to Dr. Rebecca Boxer. She will be presenting to us about heart failure disease management in skilled nursing facilities. And you might remember that Dr. Boxer was leading a study in nursing facilities here in the Denver metro area, looking at the heart failure disease management. And I was working in a building that was part of the study. So I'm very excited to hear the results and I'm very proud of you for publishing your results too. You can go ahead and bring up your slides.
Okay, I think I clicked every button. There we go. Does everything look okay? Okay, good. Hi, everyone. It's so great to come back to CMDA and talk about this study. I'm bringing forward some of a little bit more provocative parts of this research study. I think I'm close to completely recovered from conducting this study. It was quite a challenge. And I hope that you'll have a chance to look at the papers that are going to be coming out in JAMDA officially. I think they're online, and I think we also sent you copies, but come out officially in the next few months. So what I'm going to do today is I'm going to present the data from the study and talk a little bit about some of the findings and what might be clinically relevant. But it really has to be thought of in the context of a research study. So there's a lot of limitations that come out because as you try to apply it to clinical care, there's certain things that had to be done in the research that aren't very conducive to clinical care. So basically the study was a randomized cluster trial. We were in a little over 50 facilities in the Denver metro area. The physicians' practices were randomized to intervention versus usual care. And we tried to keep the physicians either in intervention or usual care. That didn't always happen over the time period because physicians would change who they were working for. But we basically tried to keep the physicians just taking care of either patients in usual care or the intervention group. And obviously a lot of physicians had patients in multiple facilities. The study was really about heart failure disease management. It was based on the American Heart Association Get With The Guidelines. And it was an RN-driven program. Also need to really emphasize, there was a research RN. So because we weren't able to get every facility research ready, which would require a lot of research training, we came in and actually conducted the program with a research team. So that's one of the limitations of this study. It's not using people who worked in the nursing facilities every day. This is a research team coming in and collecting data. And you can see here that we had multiple components of our heart failure disease management program. Clinically based measures, we assured that there was a documentation of ejection fraction in the chart. We did a symptom and activity assessment. Weights, they were not daily, that changed over the course of time, and also focused on medication titration. I'm going to go into this all a little bit more, and you'll have time to ask questions. And then we had some discharge care measures, including patient and caregiver education, discharge instructions, and a 7-day follow-up post-discharge. And these are all for post-acute patients who, with the anticipation they would be going home. So if a patient originated before hospitalization in the nursing facility as a resident, they did not meet qualifications for the study. Here's a little bit more detail. I can send out this slide set about exactly what we did and what the data was that we collected. I already kind of overviewed that for you. This is how the study was, the flow. The patients were recruited within the first 7 days of SNF admission, but we really aimed for 3 days. They received, while they were in the SNF, the heart failure disease management program that I mentioned. We followed up with the patient 7 days post-SNF discharge, either in the home or on the phone, asking them if they had measures of their vitals and their weight, their symptoms, etc., if they had follow-up appointments, or if they could be made for them. And then, shoot, I didn't mean to do that. And then for outcomes assessment, we did a 30-day and a 60-day post-SNF and hospital admissions. We found out where the patient was residing. We had a couple of ways of doing that. If they received home health care, and if they were admitted to the hospital or went to the emergency room. We had to do this both by talking with the patient, but we ended up needing also to use Creo and the National Death Index because it was very hard to find patients. And so to get the most complete data, we had to go into some of these databases. This is the consort diagram from the study. So you can see here, we looked at a lot of people to get our 671. We excluded over 6,000 patients and then allocated 329 to the intervention and 342 to usual care. You can see the unevenness there because we are randomizing based on physician practices. And so the number of patients didn't come out even between groups. And as you look through, you can see the flow of when people dropped out. We did do an intention to treat analysis. So all data we collected, regardless of what happened to the patient, was included in our analysis. Okay, so I'm going to talk first a little bit about the main study, the population characteristics, and point out a few things. Because I want to convince you that we had a population of patients that looks like the population of patients you take care of every day. And so the patients clearly were older. This is unusual also for a heart failure study to get people close to 80 is the mean. Often heart failure studies are younger. The patients also unusually were predominantly female, not unusual for the SNF population that we take care of, but unusual for heart failure studies. The other thing I want to point out is we did do a measure of function, the New York Heart Association class, with 1 being no symptoms and 4 being symptoms at rest. And we did have a fairly good representation in the classes of 2 and 3, with less so in the classes of 1 and 4. And you can see there are p-values based on these baseline characteristics, which showed that we were mostly equally distributed between our 2 groups of usual care and heart failure disease management. The other thing I'm just going to mention is the ejection fraction, since many of these patients in this age population have heart failure with preserved ejection fraction, an EF above 40. You can see here the mean ejection fraction was in the 50s. This complicates care because we're really taking care of the two populations, those with systolic failure and those with preserved systolic failure. As I get through the data, you'll see that I'm going to just have a little bit more to say about the people with the low ejection fractions. Most people had heart failure for quite a while, a mean of around 8 years, and you can see they had a lot of chronic diseases, close to 90% with hypertension, and around 40% in both groups with diabetes. Here's just a continuation of the characteristics, again, to show you that we did get a good geriatric population. You can see the geriatric syndromes in the usual care and the heart failure disease management groups. We had vision loss of, and this could include patients wearing glasses, of 90%, but lots of other issues, difficulty sleeping and chronic pain, as well as unsteady balance. Of course, they're in SNFs. So anyway, so a nice representation. Lab values were included because that is the lab values represented in many heart failure studies are indicative of poor outcomes. So those were the ones that were collected. Lab values were collected as close to hospital discharge as possible. And then further down, you can see heart failure medications, those with ejection fractions less than 40, who was on ACE inhibitors, beta blockers, and diuretics, and those who had ejection fraction over 40 in the same categories, mostly because of the guidelines indicating that those with lower ejection fractions are supposed to be on these drugs. And of course, we know that many of our older adults can not necessarily take these drugs for a variety of reasons. But the important thing is mostly equal between the two groups. And so I just want to talk a little bit about the disease management program, because this is really very informative about our success with our nurse coming into the facilities and how good they were at collecting data in the heart failure realm. So you'll see here the components of the disease management program. You'll see how many people were eligible for that measure, and then how many people received that measure. So this is going to tell us about the fidelity of the intervention, or the adherence to the intervention, how well we did, just like if we were giving someone a pill, how well or how many people actually took that pill. So documentation of ejection fraction, 93% of people had that documented. I say we did fairly well on that. Blood pressure taken at every study visit, signs and symptoms documented at every study visit in the 80 percentiles. And this is for both groups. This is for just the disease management group, because that's the one that we were intervening with the patients. Diet documented 92%. And look at our weight taken at every visit. We had a nurse coming in to get the weights, and we only got 50%. So very interesting. There's a variety of reasons for that occurred. But again, I was markedly impressed that we had so much trouble with getting weights. We also made medication recommendations according to set heart failure disease management protocols. The nurse would notify physician MPPA about recommendation. These recommendations for loop diuretics were based on weight changes, 3 pounds in 3 days, 5 pounds in a week, and also whether they should be on an ACE inhibitor or beta blocker based on having an EF less than 40%, or if those drugs should be titrated. There was 98 people who were eligible for recommendation, 34% received it. And then you can see out of those medication recommendations that were not followed by the doc or NP or PA, I didn't distinguish between the three professions. You can see that 65% did not follow a recommendation, but reported back why they didn't follow it. And that was 65%. So there was a lot of reasons why medication recommendations were not followed. It's been considered, or it's really pretty evident in the literature that medication changes are what changes outcomes. And you can see for us that it was a very hard thing to do, to make the recommendations and to have them followed in this population of patients. And I'm going to come back to that in a minute. Then you can see our education modules, at least one module completed with the patient or caregiver, 93%. All 5 education modules completed, 72%. Personalized discharge instructions reviewed, 63%. Physician follow-up visits scheduled, 60%, and nurse follow-up visit completed at 7 days post-SNF discharge, 36%. Not that great. We had trouble finding folks once they left the facility. I'm sure a lot of this doesn't surprise you. Of course, from a research standpoint, it was not, is not the way we wanted it to go. We were hoping to get better, do better on our disease management plan. This is the outcomes from the main trial. So I'm going to just walk through this a minute because it's a little complicated, but the primary analysis is 30 and 60-day outcomes of the heart failure disease management program versus usual care. Now, usual care, we collected all the same data that the facility was doing on all our measures of the disease management program, but our nurse did not help. Just so you know that usual care, we collected all the same data, but they didn't have the research nurse coming in, actually performing a lot of these disease management activities. And so on the one side of the figure, you'll see the 30-day composite outcome, which is hospitalization, ED visit, and death. So we had to pull all those outcomes together in order to get enough power for the study. And so you can see the 30-day composite and the 60-day composite. The 30-day captured almost everybody through their transfer from SNF to home. The 60-day definitely did. And at the bottom, you can see people because of the dropouts and stuff, but you can see the proportion of people who met the endpoint. And there's no significant difference between the two groups, the usual care and the intervention, in their 30-day or 60-day outcomes. Obviously, the 60-day is a little bit better, but there's no real difference. And then on the other side of the graph, you can see the mean 60-day event rate. So this is really about timing. And so when they met the event, and you can see that there is here the usual care met the event in 60 days more frequently than the intervention group, with a significant p-value of 0.039. So it seems like there is a signal there that the patients who got the intervention, the disease management program, did better at 60 days. Now, this is exploratory analysis because that was not, the rates were not what we were designed to do in this study. It was a secondary or exploratory analysis. The primary analysis was really on the composite rates on the other side of the figure. So not quite a negative trial in terms of this exploratory analysis, but still we really did not quite prove that the disease management program worked in the way the trial was set up. Okay, so let me just move very quickly to a little bit different, because I wanted to just share with you our second paper, where these are the patients who had a primary heart failure diagnosis at discharge. So what I just showed you was everybody who had heart failure as a primary or secondary discharge diagnosis. So they could have been in for sepsis or for a broken hip, but because they had heart failure, they were included in our study. This subgroup analysis just looked at the people who were actually hospitalized for heart failure. And I think this is important because you'd think that these were the people who were the most likely to get the most attention and care around their heart failure. So again, our heart failure disease management program, here we have our clinical care measures. These are the percents of how well we did for the heart failure disease management group. Documentation of ejection fraction, patients weighed 3 times in 7 days. That again was up to our nurse to do. 50% again for weights. And then you can see the rest of the measures. I'm not going to go through each one, and I certainly can send this slide set out if you want to look at it more closely. But basically, we didn't do any better in this group than the whole group. It was about the same in terms of adherence to the intervention. So what did our endpoints look like? And we did have some issues we had to deal with looking at such a small group. The total number in this group is 125. We had usual care 75, and those in disease management were 50. But what we did find that for the composite endpoint, that was a composite of death, hospitalization, and ER visit, we did see that less of the people in the disease management group, 15 versus 39, met the endpoint for the composite endpoint, which was statistically significant. So those with a primary diagnosis of heart failure did better if they received the disease management program. All of the charts for these patients, whether they were usual care or disease management, went through a clinical endpoints committee to determine whether these patients were readmitted for heart failure related reasons, cardiovascular related reasons other than heart failure, or for other, so any other reason. And you can see here that if it was heart failure related, we also had a big difference. Although we are talking about 2 small numbers to really give a p-value. We can only do the p-value for the 60-day composite endpoint. But you can see here that 12 people were readmitted versus 1 in the heart failure disease management program. And again, down the line with heart failure disease management doing somewhat better than the usual care group. We also looked at the timing of the first event within 60 days. You can see the data here. And then lastly, we did the 30-day composite endpoint, which we know that's important for financial reasons. And again, although did not reach statistical significance, you can see that the people in the usual care group with the primary diagnosis of heart failure were more likely to be readmitted than those in the disease management group. So I think this is an important signal here that we're seeing in the subgroup analysis, that the population we really need to focus on is those with a primary diagnosis, discharge diagnosis of heart failure, if we're going to use this to tell us who are the most at-risk patients. So my other conclusions for this is that, you know, if we adhered better to the intervention, if we were able to better, and I have a variety of reasons how that could have been done in retrospect, but if we had better adherence to the intervention, maybe we would have done better in the main trial in improving, really showing we can improve outcomes. But we had some serious issues that occurred with the disease management program being administered the way it was. And we also saw that that patients were really getting rehospitalized throughout the SNF stay and into the post-SNF time period. So this post-SNF time period is also important for us to think about. So I'm going to stop there. I know I rushed through that. I didn't want to overstep my time, and I might have already, but I'd love to take a couple of questions if we have time, and also suggestions and comments.
That's great, Rebecca. Thank you so much. There is a question in the chat box. I wonder if you want to take that. The question is, do you have any data on SGLT2 inhibitors? I'm guessing you didn't use that in your study, but what kind of comments do you have about that? Do you recommend it for our patients?
You know, that's a really good question, and most of this data was collected before we were using them. So I don't. And in terms of using them in this population of patients, I haven't spent much time looking into it at this point. I think it's a really important thing to consider, but I can't give you an educated answer.
No, thank you. There's also a comment from Dr. Weaver, the 60-day event signal probably reflects education and follow-up completion. What do you think about that?
I think both of those things are important. There's also a variety of other things that have come up. I think that there is a narrowness to this study with very complex patients that wasn't really attended to in the study as well as it could have been. The education, I really want to believe that made a big difference, that it made people much more aware of some of the simple things they needed to do to manage their heart failure. And there's been data that's come through over the years that has kind of poo-pooed education. But this data kind of goes against that. So I agree with you, and I think that needs to get further fleshed out, is educating and how that can be translated into better outcomes in heart failure for this population. So yeah, I think that's an important issue. It was very hard to follow up on these patients, to find them.
How very humbling to hear you say that, as well as the parts of the intervention that didn't go 100%.
Oh, yes. And there's some study related reasons that occurred, and it's also how things are conducted in facilities and how facility, the way things run intersects with research, and how to make that successful has to really be better fleshed out than I had at the start of the study. And so I think there's a lot of change. If I had to do this again, I would probably do it quite differently.
Thank you so much. I'm so honored to have you in our community doing research right in our nursing facilities and with our patients, and then also to have you have the chance to come back to us and show us the results.
Yeah, and I'd be happy. Any other questions, suggestions, please email me. I'm always interested in hearing what people's thoughts are.
Really appreciate it. If there are other questions, please direct them to Dr. Boxer. I'm just pulling up slides for the next presentation here. And this is going to be an overview of the health alert that was sent out by the CDPHE just a few days ago on COVID-19 outpatient therapeutics. And this is basically my slide set summarizing what I understand from reading the Health Alert Network. So I welcome your comments and your questions. And it looks like Bridgett, Clawson, Braaten is still on the call. She is the Deputy Director of Therapeutics for the state of Colorado. So we have a great resource to ask questions to. So the alert starts off with a summary that we have an increase in Omicron variant. As of December 19th, 91% of the Colorado sequence samples of COVID-19 were Omicron. And I'm sure that as we move forward, we will get more information about that and some updated numbers. There have been in the last week or two, several outpatient treatments for COVID approved, and they are all in very limited supply right now. And therefore, we have to prioritize people for these treatments who are immunocompromised. And we can also use risk factors for severe disease, advanced age, and not being fully vaccinated. It is very important to stress to our patients and our coworkers that these treatments are not a substitution for vaccination. The CDPHE, based on the NIH treatment guidelines, actually states in order of preference these four therapies. You can see that most of them are antivirals, and one of them, the sotrovimab, is a monoclonal antibody. And in the next few slides, we'll go over some of the features of these treatments. The first one is Paxlovid. I hope I'm saying the names somewhat correctly. It is a combination of two different antivirals. And this treatment is given with 3 tablets orally that are taken together twice a day for 5 days. And it has to be started within 5 days of the symptom onset. The thing to really know about this medication is that there are many, many drug-drug interactions. The list of contraindicated medications is very long, and it includes some very common medications that we see all the time that we can't necessarily take our patients off of. They're amiodarone, they're seizure medications, colchicine, lovastatin, simvastatin. There's also a very long list of medications to be cautious with. And you can see on this list, the rivaroxaban, bupropion, trazodone, diltiazem, amlodipine, atorvastatin. These are medications that pretty much all of our patients at one point are on. Paxlovid also has to be renally dosed, and it's not recommended in severe hepatic impairment. But it is considered the first-line treatment, probably because of its efficacy. It was shown to have an over 85% risk reduction of someone with COVID ending up dying or going to the hospital. Oops. Sotrovimab is the next treatment. This is the monoclonal antibody, and is given as an IV formulation one time. Like the other COVID-19 monoclonal antibodies we've been giving for our patients all year, this one has to be started within 10 days of symptom onset. It is only indicated for people who are outpatients, who have mild to moderate disease of COVID, who do not have an increased oxygen need. But unlike the other antibodies, this one is thought to still retain its activity against the Omicron variant. And from what I understand, and certainly other people might have more insight onto this, but the other monoclonal antibodies are not currently being distributed to regions of the country that have over 80% of Omicron. That being said, the CDPHE seems to be recommending that if you know that a patient does not have Omicron, at that point you could consider using one of the other monoclonal antibodies. The sotrovimab is only available intravenously, and it is not indicated for post-exposure prophylaxis. Remdesivir, this is the antiviral treatment that up until now has only been available for inpatients. It is given by IV every day for 3 days in a row. It should be started within 7 days of the symptoms, and you need to monitor the renal and hepatic labs. Remdesivir is considered effective against Omicron. And the interesting thing to me is that right now the NIH and the Infectious Disease Society are recommending its use for outpatients, for non-hospitalized patients. But the FDA emergency use authorization has not changed, so using it in that setting would be considered off-label. The Malnupeurovir is the last antiviral medication mentioned. It is considered to be less effective than these other approved treatments. This is a medication that is given as 4 capsules orally every 12 hours for 5 days, and it must be started within 5 days of the symptoms. The main contraindication is pregnancy. There are no significant drug-drug interactions, and there's no renal or hepatic adjustment. It seems like it would be very simple to prescribe, but the reason it's not one of the first-line treatments is that the risk reduction was much lower compared to the other treatments. It looks like it had a 30% reduction in the risk of death or hospitalization from COVID. Evusheld is mentioned in the recent HAN for the pre-exposure prophylaxis. This is a monoclonal antibody that reduces the incidence of COVID-19 and severe disease or death. This one is given by IM, with a series of 2 IM injections given back to back. It is expected to retain its efficacy against Omicron, and currently it is being prioritized for the severely immunocompromised individuals only. All of these treatments are summarized in a table through the CDPHE Health Alert Network. It was sent out on December 31st, and we included it in the CMDA email with your agenda. I know that the Geriatric Journal Club is planning to discuss COVID-19 treatments in next month's Journal Club, and hopefully by then we'll also have more information about the medication as well as more supply. Thank you very much. Does anyone have questions about these treatments? I'm sure I won't know the answers, but happy to try to find them for you. And then, as I mentioned, we have our representative from the CDPHE still on the call. And if not, we can move on to our next presentation, which will be given by Dr. Leslie Eber.
Thank you. I will try to move very quickly, and I'll share my screen when you're ready, Sing.
Okay. Sorry, I'm trying to find the button to stop sharing mine.
Sure.
Okay, you should be allowed to share yours now. Thank you.
All right. I may go a minute or two over, so you may have to forgive me. Hold on a sec. Okay. Can you guys see my slides okay?
I can see them.
Great. So we're going to end with talking about COVID-19 vaccine misinformation. It's really out there and it's hard to know how to effectively deal with it. So there's been a lot of research about this, and this is a quick presentation on what we can do. So first, I thought we would start off with some definitions. Misinformation from social media with the COVID-19 vaccine and with any type of medical misinformation is information that's incorrect, but is not purposely spread to cause harm, versus disinformation, information that is incorrect and is spread to cause harm. And of course, the difference is intent. All righty. So, hold on, I have to be able to see my slides. Hold on a second. So first, I'd like to set the stage for medical misinformation. And first, to acknowledge that we all have a training gap. We have not been trained in medical school or in post-education from our medical school and our residency programs to talk with folks about medical misinformation. How do we have those conversations? So we're kind of, a lot of us, most of us are starting from scratch. And the disinformation spreaders were really organized very early in the COVID-19 pandemic. They really saw this as an opportunity to convince people that all vaccines may be harmful. And so we were a little bit late to the party as well. There's also the information cascade, as one story leads to another story, especially on social media. And what was really interesting is that we found over the past 2 years that this information is really breaking out of its echo chambers. It's not just kind of preaching to the choir, but it's coming into the general public and their social media trends. And so that's really important to know. And they've really done their research, they've done their homework. What messages are going to resonate with different groups and really targeting certain groups for disinformation. So in the end, it's very difficult to convince somebody who has a steadfast belief in their misinformation, and that people then are interested in winning over the fence sitters. We also have to acknowledge that even though the Kaiser Family Foundation data very clearly shows that providers are often the most trusted person that any individual will turn to for medical information, we often get just 15 or 20 minutes with folks, whereas many people spend 2.5 hours or more on social media. So they get a lot more face time than we do, and no pun intended. Also, nobody is really making videos of their perfectly normal COVID-19 vaccine experiences. And this is what we can call kind of an asymmetry of passion. You know, when we drive down the highway and we turn our head to see the big accident because it's unusual, nobody is looking around saying, look at all the normal drivers. This is amazing. Social media videos often have emotional weight, kind of pull us along with sensationalism or pulling at our heartstrings. And so we have to also know that that is an influence as well. It's important, I think, to talk about how COVID-19 virus spreads and how misinformation and disinformation spreads equally so. They're very parallel. And there are super spreader events with misinformation, with large platforms and many followers. We can think of lots of examples of the analogy hydroxychloroquine and vermectin. So why is it that misinformation spreads faster than the real McCoy? And really, our pandemic has really demonstrated this, unfortunately, really beautifully. There is a promise of certainty and the alleviation of fear. That's something that misinformation and disinformation addresses that our scientific process often doesn't. Really, our scientific process asks us, especially during the pandemic, to wait. Just like with Omicron. Is Omicron more severe or less severe? And everybody says, oh, in 2 weeks, we'll know more. During those 2 weeks and that data void time, it's really uncomfortable. Wouldn't it be great if we could go to Facebook or to some other social media and find the answer immediately? Wouldn't we maybe feel better and less anxious? And so that's some of the reason why misinformation spreads so rapidly. It's also a novelty, and it's kind of cool, and you're kind of cool if you share that novelty. So the good news, and if there is one slide that I would encourage people to take advantage of, it would be this slide, is that not only can we vaccinate people against COVID-19 virus, but we can vaccinate them against misinformation, disinformation. And so that's an incredible opportunity. First, we can warn people that misinformation and disinformation are rampant, especially on social media, and talk about that. And provide defenses. What are things that people can do to protect themselves against being sucked into misinformation? Use fact-checking and cross-referencing. Review trusted sources of information. Are they agreeing with this social media post or not? Consider the motives behind the information source. Is it fame, sensationalism, harm? Is it scientifically sound? Some of the current research says that even folks who have a small amount of statistical education can say, gosh, this was a study of 4 people. Maybe the fact that it was 50% effective, maybe that's not really scientifically sound. And then talk about the scientific process, how we ask a question, and then we look at the data for answers, and maybe we change our answers, or that leads us to another question. And really own the fact, and this is really important to say out loud to folks, that some questions don't have answers yet. If anybody tells you that they know the exact day when this will become an endemic instead of a pandemic, well, that answer isn't available yet. That's really a data void, and it's important that people are aware. And then finally, discuss techniques for deception that we're all vulnerable to. Fake experts, it can be an expert, but maybe this is an ophthalmologist. And they're often a mixture of facts and lies, and that really makes the lies more believable. So maybe some of the things that are read on that post are true. And so it's important to let people know about that. Misinformation debunking for specific communities can be really profound. And of course, the best person to do that is a person from that community. Then the messaging is authentic for the community, and doing the messaging in the appropriate language can also be very effective. So strategies to address when you're in that conversation, what do you do? And so the first thing I do, besides take kind of a little bit of a deep breath, when the person's telling me that they're not going to get the vaccine because of that microchip that's embedded in the vaccine. And then I don't take the misinformation personally. I don't get frustrated or angry, even though it's been a long road with the pandemic and it's easy to get frustrated. You listen first. People want to be heard. And remember that even if you can't debunk someone's steadfast beliefs, you can absolutely validate the fear and emotion behind that belief without validating the misinformation. You can show respect always. Don't show anger and frustration. They're not effective. And then celebrate the fact, and this is the part where I pivot. I celebrate the fact that the person trusts me enough to have the conversation. And so this is an honor. Find common ground first. What do we agree on? We all want the pandemic to end. We all want to be able to go out for dinner without thinking about a mask. And then build trust upon that relationship, which is probably already there. Remember, the goal is not to prove them wrong. Education alone will not debunk misinformation, and we know that to be true. All right, so I have like maybe 1 or 2 more minutes. These are some ideas also that you can use in addressing medical misinformation. First of all, try to sort out why this information is speaking to the person. What are the underlying reasons for it being so sticky? What are the emotions behind it? Take the opportunity to redirect them to more trustworthy information sources and tell them what you know to be true medically. Ask them to consider, where's information coming from? Is it gaining popularity because it's sensationalized? And is it being confirmed? Is it scientifically sound? To debunk misinformation, you really should have two elements. Why is it now clear that the information is false? And what do we know instead that is true? And encourage all people, including ourselves, to have a buyer beware stance towards all information you see on social media. Slowing down, thinking about the information provided, and evaluating its plausibility in light of possible alternatives. And this really directly builds upon Daniel Kahneman's idea of system 1 and system 2, so that if we slow down and we consider alternatives, we're less likely to make mistakes, and we're going to make better decisions about what is believable. So then just a few more things about how to have this conversation and some wording that you can use in these conversations. Always acknowledge the concern. I see you've been thinking about this a lot. And then encourage discussion. Don't shut them down. That is not helpful. It takes some time and patience, but it's well worth the investment. Ask questions. Tell me where you heard about this information. Do you trust the source? Never be condescending. The person is trusting you to have the conversation, and don't say really negative things. That's crazy. That's completely incorrect. When people see your body language and those words, they back away and the conversation kind of ends. And so does your opportunity. Offer to trade sources, tell them what you know to be medically true, and also acknowledge their concerns. Gosh, that's a good question. Let's talk that through. So this is my last slide. I couldn't help but post it. This is from a great Stanford podcast, was just done in December 2021 about misinformation and specifically medical misinformation. And they talk about their strategy for talking about the COVID-19 vaccination. It's called This Is Our Shot. And it's a 3-step method: listening for the emotion, validating the concern, and then finding their compelling reason to get the vaccine. When you lead with listening, then you're going to have a shot. Don't lead with facts. We're tempted to do that because we're scientists at nature, but really leading with compassion and empathy is more successful. Thank you very much. Now I'll just stop.
Thank you. Very timely, very important information. And I really appreciate the words that we can use. I will use that for my practice. Are there any questions for Dr. Eber? Well, at this time, we will conclude our meeting. We thank you all for joining us. Just wanted to remind you that the CMDA annual conference will be on Friday, April 29th in Denver. This will be a fully vaccinated and boosted live conference, but we are looking into ways to allow people to join remotely. The next CMDA monthly meeting will be on Tuesday, February 3rd from 12 to 1 by Zoom. Thank you all so much for joining us today.